Let's talk about HIV and AIDS. The AIDS epidemic, there's been a lot of efforts and work that has gone into addressing HIV and AIDS in the country. We have various government programs that have been rolled out, supported by external donors. A lot of money that has been spent. The other day, we were talking about whether the country will actually be able to take over self financing and resource mobilization for HIV and AIDS programs. At the same time, we know that UNAIDS had also come up with, this global ambition of saying, first one was 90, then they adjusted and said 95. City, what does that mean? What's 95?
Well, it was ambitious in the sense that it was aspirational, but essentially, what was being aimed for? They said, look, we have this problem with us. Now, people hear the word pandemic, they hear the word epidemic, and they wonder, what are you talking about? Well, very simply, an epidemic is something that affects many people. A pandemic is when this epidemic just goes beyond many people to countries, and it probably goes to a much larger geographical areas. So it's really widespread throughout the world. Then you call it a pandemic. Like COVID is a pandemic. If it was only nestled in one particular area, you'd call it an epidemic. Okay? So the understanding was, you look at HIV and you wonder, how on earth do we focus our attention so that we know what it is we are looking at, and how do we get granular in determining what it is we need to focus on in order to reduce it and start working towards eliminating it. So it was, first of all, you want to make sure that 95% of the people who actually live within your boundaries have been diagnosed, meaning they've been tested. So we've tested 95%. It started with 90, the reality was achievable, so you test 95%. Then you want to make sure that those are put on the effective treatment. They are put on ARVs, okay? Then lastly, you want to make sure that they are virally suppressed. That was the understanding. So the 90 or 95 represents the aspirational percentage that was being aimed at. And the understanding was that if you can achieve this, then you will be able to actually not just contain, but win this battle against the HIV infection. That was the understanding.
So a lot of work is being done, various programs being rolled out. Like there's the Amref Kibera Reach 90 project. And we'll be speaking about that shortly. Joining us on the line this morning is Dr. Anne Kerubo. She's the acting program manager and in charge of care and treatment at the Amref Kibera Reach 90 project. And also joining us shortly will be Dr. Lazarus Momani. He's a technical advisor and program manager for HIV care and treatment at the National AIDS and STI Control Program, NASCOP. Let's begin with Dr. Anne Kerubo. Good morning, Dr. Ari, and thank you very much for joining us. Welcome to the Situation Room.
Good morning. How are you?
We're very well, thank you, and we are privileged to have you on the show. Tell us about the Amref Kibera Reach 90 project. What's it all about?
Once again, thank you so much for having me on the show. Such a pleasure to be here. I'm always listening to this show when I'm driving to work, back in the days when I used to drive. So Amref Kibera Reach 90 project supports HIV implementation in Kibera, which is an informal settlement. And we've been there for about slightly more than 15 years, supporting the HIV activities within Kibera. So currently, we are supporting 8 facilities within Kibera, Langata, and also there's one facility in Kapkunji sub-county. And so we have several activities that we support in terms of HIV and being CDC funded. So we offer support in terms of HIV testing services. We also offer care and treatment services to those who are enrolled within the program. And currently we have about slightly over 11,000 clients who are within the program. And we also support PMTCT program, that is prevention of mother-to-child transmission. We also support gender-based violence. We have one of our nurses who's a champion in offering the service, especially now with the pandemic. You've seen quite a number of cases coming up. We also have the PrEP services, that is pre-exposure prophylaxis. So we offer that to especially like our clients who are eligible. That is, if you have a positive partner, then you're able to be prevented from getting HIV by using the PrEP. Then we also support laboratory services, just in terms of viral load testing and other tests that we do to monitor our clients who are on treatment. So that's majorly what we do in the program.
All right. So, I mean, these ambitious numbers that we're looking towards, Doc, 95, 95, 95. Previously, it was 90, 90, 90, and we're looking at the year 2030 to be able to get to a place whereby, essentially, HIV AIDS in the country is managed, has been managed, and that those who are unwell are being treated, and that you can keep a viral load suppressed. How are we doing in terms of progress? Because 2030 is 8.5 years away. It's not very long. So what's the progress so far, if you were to give a bird's eye view of things?
Okay, so if I can just give like an estimate from the survey that was done in 2020. So overall, though I think also Dr. Lazarus could chip in, but from the estimates, the viral suppression is currently at 87.5%. That is in Kenya. And when you look at Nairobi County, it's about 84%. But for our project, we are currently at 94%. That is according to the data in the DHIS. So we have differences in terms of viral suppression among our clients, and that depends majorly on their adherence to treatment. So you may find there are clients who are adherent and they will have suppressed, but there are those who are not. So that is what builds up to now the total viral suppression for all the clients. So it's still work in progress that we are working towards to ensure that they are virally suppressed. And if you look at probably this time when we've had the pandemic, it means most of the clients were not able to probably come to the facility, especially when we had the restrictions to movement. So we've had to come up with ways just to reach out to them so that we're able, so that we're able to still monitor their progress and ensure that they're adherent to treatment. So I think one of the things that has helped us is having virtual sessions with them. Not necessarily like a video, but at least even just a phone call to monitor their adherence to treatment, find out if there are any barriers, anything that they're struggling with, so that they're not able to take their medication, and the counselors, the adherence counselors, are able to work around it, and they come up with a plan of action of how to suppress. So that's one of the things that we are trying to do, just to make sure that they are they're achieving viral suppression at the end of the day.
Let's bring in Dr. Lazarus Momani as well onto the show. Dr. Momanyi is a technical advisor and program manager, HIV care and treatment at NASCOP, and this is the National AIDS and STI Control Program. Good morning, Doc, and thank you very much for joining us as well.
Thank you so much. Good morning to you.
Now, Daktari, from the government side, because NASCOP is MOH, there's a lot of work that's being done in terms of looking at the progress that, just like Ndu was asking Dr. Kerubo, of taking us towards achieving this ideal of 95, 95, 95, and seeing how we can then end AIDS epidemic by 2030. This 95, 95, 95 strategy, Dr. Kerubo has just given us the figures of according to the statistics that came out last year. But she said there's a lot more that you have information that you could actually share with us. What can you tell us? What 95, 95, 95? What are we doing? How are we doing from the first 95 to the last 95?
All right. Thank you so much for that question. And I think one of the things I want to point out is that the 95, 95, 95 is actually a global strategy. by UNAIDS, and it's applied across the whole globe. All the countries are working towards achieving the same target. So as a country, I will first start saying that we have made a lot of good progress. So the first 95 is really saying that out of all the people who are estimated to be living with HIV in Kenya, how many of them have we been able to identify and eventually put on treatment? So from our estimates, we know that we have about 1.5 million people living with HIV as per the 2020 HIV estimates that we do biannually. And from those, we've been able to actually identify 1.2 million people and put them on treatment. So when you look at that, it gives us an ART coverage of about 82%, meaning that then we still have about 300,000 people that we still need to identify to be able to reach that 90%, also to be able to actually identify all of them and put them on treatment. So we still have a gap. And when you look at that gap for the first 90, we actually have a larger gap among children, because for children, our ART coverage is only currently at around 7% compared to the adults, where we're actually doing much better. So in terms of the second 90, which is basically for those that you have been able to identify, how many of them are you able to put on treatment? So we are actually doing very well in the second 95, because we know that at least for those who we are able to identify, put most of them on treatment, they're actually performing over 90%. In terms of the third 90, which is basically now for those that you've been able to put on treatment, are you able to achieve viral suppression for them? And there are two advantages of virally suppressing patients. One is for their own health, because we know that once a patient is virally suppressed, then they have a better immunity, and they are able to have a quality life, less of opportunistic infections, less of hospital admissions, and they're able to do their work normally just like any other person. And the other advantage of having a viral suppression is something we call U is equals to U, which basically means undetectable is equals to untransmittable. And the research has actually shown that when you're virally suppressed, then your chances of transmitting the virus to another person, in the case of, for example, an unprotected sex, is almost zero if you are virally suppressed. Of course, we don't say zero, but say almost zero. So there are two advantages: the old patients and also for purposes of prevention. So in terms of the last 90, for adults, we're actually doing over 90% at around 93%. For children, I think about 87%, as the doctor mentioned. And so we know that we are lagging behind in children, but we are really making very good progress. Some of the things we are doing, especially for the third 90, that maybe we can later discuss, really optimizing our ART, ensuring that every patient is on the right and the most potent and the most friendly regimen to be able to suppress the virus. Thank you so much.
Dr. Momanyi, let me ask this question. When you say that we have identified a certain percentage, an 80-some percentile of people who are HIV, are you saying that out of the 45 to 50 million Kenyans, that percentage speaks of the 45 million?
No. So we have the population of Kenya, of course, which is over 45 million, as you've said. But then after every 2 years, we use some mathematical models which combine a lot of data, including the people who are turning positive at the hospital, the mothers who are turning positive at the antenatal clinic. So we use a mathematical model which is actually used worldwide. And this mathematical model is able to estimate to us how many people of the entire population are estimated to be living with HIV. So in Kenya, it's estimated that out of the entire population of over 40 million plus, we have about 1.5 million people who are living with HIV, which gives us then helps us calculate what something called a prevalence. So in terms of HIV, we actually measure two things. One is prevalence, which is basically what percentage of people of the entire population are estimated to be living with HIV, and specifically the burden of HIV in the country. The other number we use, the other statistic, is something called new infections. That is incidence. So it says that in every year, how many people are newly getting infected with HIV. So both of those statistics are very important. So to answer your question, the number we are talking about, our denominator, is the number of people estimated to be living with HIV, which is 1.5, and not the entire population of 40 million plus.
And this is based on the number of people who visit hospitals or who present themselves voluntarily for testing. Is that so?
Yes.
And of these people, what percentage are there of the people who live in Kenya, of our population?
Okay. So our prevalence is around 5%, and this keeps on changing. I know previously we talked about 7%. So every time we do our statistics, we get a new prevalence. So the current prevalence, which is at around 5%, is basically the number of people who are HIV positive out of the entire population. So that is the one we use. And basically, it's not all the people who come to the facility, because we know that some people have not been identified, meaning that they're still at home and don't know their status. So, for example, when we say we have 1.5 million people estimated to be living with HIV in Kenya, we have only been able to identify 1.2 million out of the 1.5 and put them on treatment, meaning that there's another 300,000 who have either not yet been identified, or if they were identified, they were put on treatment and then they disappeared from treatment. So basically, that is how we look at it.
I'm still looking at these numbers of 90, whether we're looking at 90 or looking at 95. And if this is a target being achieved, and I think this is for both of you, Doc and Doc, if this is the target that we are trying to get to by 2030, where is behavior playing a role in all of this? And what kind of trends have you seen so far? There were a few years here where nobody was really focusing or talking about, behavior that would then lead to infections of HIV. Are you taking that into consideration as a factor that would then help to achieve this target by 2030? And are we seeing that people are behaving as it were, and so then reducing the numbers of infections?
Okay, maybe if I could go first. Mm-hmm. So, like for our project, we've had to come up with ways of reaching out to the clients who need to get these services. And I think the most important thing is to create that awareness continually, and we've been able to do that through the community health volunteers. So we have them especially working in like our setup, Kibra, and they're able to go door to door and give the messages to the people so that they're able to come to the facility for these services. We know for behavior change, it must be one of the things that we used to do previously, like initially when HIV programming started. I think there was a lot of messaging around behavior change, and that is still there because we know that if you're able to achieve that, then you'll be able to reduce the number of infections. And I remember back in the days, we used to say of abstinence, being faithful, and use of condoms. So there's a lot of messaging still that goes out there to ensure that the people are able to also seek for more of the services, because one of the important things to know is your status. So if they can be tested and know their status, then that way we are able to ensure that if you're HIV positive, you're not you're going to be careful not to acquire the virus. But also, if you are HIV positive and once you're enrolled into the program, you're started on treatment. And we want to ensure that you are virally suppressed so that you're not going to transmit that virus either to your partner or to your spouse. So behavior change is still there, even among not just when you talk of like sexual transmission, but also we have like the intravenous drug users or the ones who use opioids. So we have all those messages that go around.
Having a conversation with two doctors, Dr. Ann Kerubo and Dr. Lazarus Momani. Dr. Kerubo is a program manager and care and treatment at AMREF Kibera Reach 90 project. And Dr. Momanyi is a technical advisor and program manager for HIV care and treatment at the National AIDS and STI Control Program. What are we doing? How are we doing in the ambition to end HIV AIDS in the country or in the world by 2030. The 95-95 UNAIDS strategy. How far have we gone on that?
Oh, now to you, Dr. Momanyi. Let's take the view that hypothetically we achieved the 95-95-95 goal. Will this mean an end to the HIV scourge? Will it now come to an abrupt end because we've reached 95-95-95?
Thank you for that question, and I think it's a very pertinent question that people ask. When you say you want to achieve 95, does it mean HIV will disappear? The answer is no, because one, what you really want to achieve is to ensure that we stop or we bring the new infections to the minimum, meaning that for the people who have already been infected with HIV, we don't want to add more people. So as I said, remember that we have 1.5 million people on treatment who are estimated to be living with HIV in Kenya, and we want to keep that prevalence either at that level or even lower. But in terms of the ones who are already HIV infected, and we know that currently you're talking about even children who are 1 year old, and all this, we want to put them on treatment. And what we want to ensure that they actually live as long as they will have lived if they didn't have HIV, meaning that they have a quality, lifelong life. We know that antiretroviral treatment is actually lifelong treatment. It's not medication you take, and it's kind of HIV disappears from your body. You have to take medications to be able to suppress your virus, and you have to take it for life. That said, of course, there's a lot of research going on and a lot of science to maybe in the pursuit of a cure for HIV, which is not yet. We don't have any cure that has been discovered or is licensed by the Food and Drug Administration, the FDA. A lot of research is going on. As you know, probably it's only 2 patients have been able to document complete cure or remission of HIV in their bodies. Otherwise, as it is right now, HIV is a lifelong treatment. So even when we achieve our 95, we still expect that those who are already infected and on treatment will be growing up. Some will be growing older. The children becoming adolescents, the adolescents becoming young people, the young people becoming middle aged, and therefore we still ensure that we have people on treatment. But the only thing we really want to stop is the new infections, and new infections can occur both from mother to child, but also among people through sexual intercourse.
Dr. Kerubo, I still have a question for you. You talked about behavior change messaging. Do you know of any research or any process that can be presented as effectively measuring the efficacy or the effectiveness of this messaging so that the end result being behavior has changed? Do you know of cases, or do you know of incidents, or do you know of programs that have guaranteed that these messages have actually brought about the desired results or the desired change?
Okay. I may not know of a program or any research that has been done, but from, I think, probably one of the initiatives that really works on implementing behavior change is like the DREAMS program, where we have, it's a program for empowering especially the adolescent girls and young women. And part of that is just addressing some of the challenges that these young girls normally face, because you would find that probably they are not able to go to school for one reason or the other, or they are engaging in unprotected sex, maybe because they don't have the knowledge or they don't have finances, so they are trying to make money so as to provide for themselves. So we have interventions through that program, and they're able to reach out to these girls and mentor them so that they're able to make the right choices, at least make the choice to go to school, complete their education, maybe provide for them some of the things that they need, like sanitary towels, which probably they would go out and look for money to buy them, or even at least provide maybe a stipend of food or some money for food, so that they don't have to go out and look for money from other people by engaging in like sexual activities. So I don't know if there's any program that is actually measuring the impact of the behavior change initiatives, but it's something worth looking out for.
So in essence, we're saying we don't really know whether these messages actually produce the changes that we desire. Is that what we're saying?
Probably, maybe I'm seeing Dr. Lazarus is wanting to chime in, but
All right, Dr.
So
Lazarus,
probably-
chime in if you may.
Thank you so much. And I know you're putting Kerubo on the spot, but
Actually, I'm asking a simple question. It is you who's putting her on the spot by mentioning the spot, which I didn't put her in the first place.
Yeah, so what we currently advocate for is what we call preventive combination method, which basically means that we use more than one intervention, because we previously know that previously we talk about ABC, which is basically abstinence, being faithful, and use of condoms, and this didn't work or has not worked very well. So currently, as he said, we are using additional also biomedical interventions in addition to the behavioral change interventions. That will include things like what you mentioned, PrEP for those who are at risk of getting HIV or being HIV infected. We also know that we are also having treatment itself is a prevention, but also the other things we're using, including even male circumcision among men, and a number of other things. But that said and done, I think the question is asked is still very valid, because for any intervention, we really want to know whether this really works. And if you look at the pattern of new infections that we do have, you'll actually see that majority of the 46,000 new infections every year, about 14,000 out of those are happening amongst those 16 to 24 years, and specifically amongst adolescent girls and young women. And this is also concurrent. If you look at, again, the pattern, you actually see that also there's a rise in terms of teenage pregnancies amongst the younger. Like last year when you saw people doing, this year when you saw people doing KCT, you could hear in school X, a young girl has just delivered. She was doing an exam from the ward where she had just delivered a child. So a lot of teenage pregnancies and young, the sexual debut at the age of which girls having sex, or even boys, has actually come down even to 10, even 9 years. So that's why I think we're hearing Dr. Ann mentioning things like the DREAMS project, which is actually targeting adolescent girls and young women and trying to empower them, and really going to the root cause as why they will engage in some activities that actually lead to early teenage pregnancy and new infections. So in terms of being able to measure, I agree with her that we actually don't have really a specific measure that can help us to be able to say whether this specific behavioral intervention works, because we are actually using it in combination with the other interventions, including even self-testing. As you know, right now, we are really advocating for people known to their status. So meaning that actually if you go to a chemist, you can actually be able to access a self-test, 150 shillings, or even for free. So these are all interventions we are putting in place. Overall, actually, if you look at the pattern of new infections, we have actually come down from 106,000 new infections in 2012 per year to 46,000, which actually we've been able to do, but the 46,000 is still high, and they still need to do something.
A lot of the work that was done with HIV over the last, few decades was heavily funded, external donor funded. And now, as we're heading towards 2030, with some of these interventions that clearly government wants to put in place, as well as, other social bodies, how will this be taken care of? And I can hear that a lot of the focus now is treatment driven in terms of funding and then access to what is needed. Is it enough? And what are the calls then on national government, since clearly that funding is dwindling?
Thank you so much. Maybe I could go first, and Dr. Ann could add something. Yes, you're right. And part of the reason why actually funding has gone down is because Kenya now has been classified as a lower to medium income country, meaning that we are no longer where we used to, classified as just a resource who are set up. It means that we are actually able to generate our own income. The middle class is growing and all that. So in terms of funding, yes, you're right. We're actually talking about over 8% of the HIV response. That's talked about from the human resource to the drugs that we do use, some of the commodities used to test people and even monitor people on treatment, and even the things I've mentioned about PrEP. Up to 80% is actually funded externally through either the PEPFAR program or through the Global Fund. and the government is only able to chip in less than 20%. So there's actually a plan to increase it. And if you look at the current budget that was read, you could actually see that now the funding or rather the allocation that was given to TB and malaria and HIV was significantly increased. Now we're talking about almost 9 billion Kenyan shillings that is going to be allocated by the Kenyan government. And I think from the current impasse that you know about the drugs and with the USAID, actually a lot of lessons learned and a lot of wake-up call to ensure that you actually incrementally allocate our local or domestic resources. And other countries in Africa have actually been able to do it. In like South Africa is the reverse. The government actually does 80% and there's only 20% external funding. That said and done, the other sector that has been or is being looked at critically in terms of coming in strongly is the private sector to be able to bridge the gap. And there's a lot of engagement going on. Currently, nationally, we are developing what we're calling a private sector engagement framework to bring in the private hospitals. Some of the people might want to fund some of the HIV work or response that you're doing. Currently, as you know, for a patient, an adult patient, you need about 7,000 to get off your drugs in a year. And we know that even a number of people now have NHIF that can be able to cover for some of these costs. And even some of the private hospitals can actually bring down some of the costs for that we are seeing people incur. So all these are efforts that are being made to actually ensure that we are going to what we call a journey to self-reliance. And I would say that we still have a long way because we are at less than 20% domestic funding. But over time, I'm sure that we actually shall be able to get there.
Dr. Momanyi, I like your enthusiasm and your optimism. But we now at a phase in our fight against the HIV scourge where I believe we test and then we treat. Am I right in saying so?
Yes.
Okay.
Yes,
and that is research driven. I know that there was a research that began in 2013, Sustainable East Africa Research on Community Health. And the proof of that particular concept was derived from this particular study. I understand that. However, as NASCOP, as government, when we talk about being self-reliant, the discussion is a good one. The aspiration is a good one. But let me just mirror it against the reality, okay? Are we actually able to ensure, given that health is a devolved function, to allocate the adequate resources that will enable us to actually provide the care and treatment that people who are living with HIV can actually get what they need? Is it actually possible?
I would say a big yes. It's actually possible. One of the things that has been done is to actually be able to post what does it take to be able to provide an HIV response in the country. And we are talking about 84 billion Kenyan shillings. That's what it costs to test people, provide all the commodities, provide all the infrastructure that's needed to be able to actually provide an HIV response. So having said that, as you said, yes, we are actually a long way, and what we are saying basically is very ambitious. But I would say that the journey has started, and we are already we're already making strides in the right direction. One, if you look at, as you said, clearly health is a devolved function, and currently what the National AIDS Control Council, that's NAC, is doing, and we work together with NASCOP, is to help the counties to come up with what we call County AIDS Implementation Plan, KAIP, which basically says that each county now is trying to look at what is the burden of HIV in the county, what do they need to put in place in terms of interventions, and what does it cost to be able to provide those interventions. So they've been able to cause this KAIP, and if you look what the recent...
Dr. Lazarus Momani, that information has been available for a long time, because when funders fund you, they go into the pains of ensuring they have all those details, and this is something you know. Now, my question, let me perhaps simplify it. What I'm saying is,
yes,
do we have the will to do what we need to do? Yes, we can do it. Do we have the will to do what we need to do? That is perhaps a more pertinent question.
Yeah. I think the will is there, and the will has to be informed by data. And as much as to say that the information has been there, the information has actually been there, but at a national level. You look at what we call a national strategic framework, with the information. But the counties have never been able to do this. And actually, if you look at one of the counties that's been able even to allocate resources, Kakamega recently was the first county to go the right direction of actually allocating resources within the county for the HIV program. So I would say that the will is there. There's been a lot of discussions, a lot of engagement with stakeholders. If you look at some of the forums that have been happening since we have this impasse, one of the wake-up calls actually that has come very clear is that we need to put in more resources. We need to provide more domestic resources to be able to fund and support our people living with HIV to be right on stream. And we can no longer rely on external donor funding because, I mean, a surprise can happen like just what happened, and we don't have, or we might end up not having the drug on treatment. So I would say that the will is there. There's been a lot of discussions, but I think a lot needs to be done to ensure that we're actually able to put our money where our mouth is.
Dr. Kerubo, as we conclude, what do you think needs to happen to get us to that stage where we are actually able to finance ourselves using this same framework that we're talking about under the devolution framework?
Yes, thank you. I agree with Dr. Lazarus that a lot of this will be guided by the data which is currently there, and also a lot of advocacy needs to be done so as to guide the government to ensure that they have an allocation and enough allocation, not just a small amount, so that we are able to sustain the gains which we have currently in the HIV programming, because there are so many things that are donor funded, including even the HRH, and we need to slowly move all that to the counties and even the national government in terms of funding. So there's a lot of advocacy that needs to be done so as to ensure that the allocation is done and it is done correctly using the data that we have.
Thank you for joining us there this morning, Dr. Aris. We hope the next one you'll be live in studio. We'll have dealt with COVID-19 and we'll be okay to actually host you in the studio. Dr. Ann Kerubo is the acting program manager in charge of care and treatment at Amref Kibera Reach 90 project. And Dr. Lazarus Momani is a technical advisor and program manager for care and treatment at the National AIDS and STI Control Program. Have a lovely day.
Thank you so much.
Thank you so much for having me.